We're going to talk a lot about advanced disease, but Eric, what about genetic testing in advanced disease? Is there a role, and what role does it play?
I mean, I think it plays the same role that we just talked about, that if someone comes in advanced disease, you want to know what are you going to do about the family members, but you also want to know what you're going to do about the patient themselves. So if they do have like a Men's syndrome, especially before surgery, you need to watch out for the catecholamines. And I think the general rule, probably even for early on, before even waiting for the red test to come back, if you're going to do a thyroidectomy, you have to check serum catecholamines or urine or plasma, or urine. So it is pretty important, especially in these patients who may live a very long time, even if they have metastatic disease, that you know what other complications that you have to watch out for.
Well, I think that's particularly important for oncologists, because in the past, these medullary patients had almost always come through an endocrinologist before they got to you guys. But now with the targeted therapies and medications that are there, some of these patients are going to come straight to the oncologist even before they have their thyroid taken out. So evaluating them for pheochromocytoma and hyperparathyroidism before we pile down some sort of systemic therapy is now going to be in the oncologist court, as well as like when the occasional patients get sent to the surgeon. They have to be able to do that as well. So I think that's critical.
Yeah. Lori, I think you mentioned that there's a genotype-phenotype association here, and does that inform prognosis as well?
It does. The prognosis is different for patients with the various familial syndromes, as well as for patients who have sporadic disease that harbor RET mutations within the tumor themselves. So, for example, we talked a little bit about the genotype-phenotype correlation in terms of age of thyroidectomy. So the mutations associated with MEN2B are associated with development of medullary thyroid carcinoma very early in life, and those children need to have thyroidectomies by the age of 1 year old in general. The prognosis for MEN2B is worse than the prognosis for MEN2A in general, particularly when it comes to medullary thyroid carcinoma. So then if we can basically translate that information to the sporadic medullary thyroid carcinoma as well, which is more common than familial medullary thyroid carcinoma. So in the tumors that harbor RET mutations, particularly the most common mutation, which is the M918T mutation, there is actually a worse prognosis for those patients, even when they have sporadic disease, compared to the medullary thyroid carcinomas that don't harbor that one particular mutation.